And as ma'am said, we understand the complications and the perceptions of families seeking out the obstetrician, and Dr. Shilpi understands what is the expectation when it comes to neonatal care. And for today's panel, we are going to discuss about perinatal interventions that have been shown to improve outcomes in extremely preterm neonates. We are extremely thankful to the chairpersons, Dr. Amit sir, who has come from Gilead. He is the Secretary of National NNF now. Dr. Sriselam sir, President of State NNF this year. Dr. Swarna, who is the Secretary of Telangana State NNF, and Dr. Shivaranjani Santosh ma'am, a passionate pediatrician. To take us through this panel, I am extremely pleased to invite the team of panelists. We have two obstetricians, two young and dynamic obstetricians, and two neonatologists. I would first like to call upon Dr. Veena, MS OBG and Fellowship in Obstetrics, consultant at Cuddles, Kondapur. Thank you, Dr. Veena, for joining us. We also have with us Dr. Anuvardhan. She is again a very young, dynamic, enterprising obstetrician. She is currently pursuing her fellowship in high-risk pregnancies from Fernandez Hospital. Welcome, Dr. Anu. Please do join us. We have with us our passionate team member, Dr. Aravinda, with whom I've had the pleasure of being associated for more than 4 years now. Dr. Aravinda is a DMB from Pediatrics and Fellowship in Neonatology. She works as consultant neonatologist at our team in Cuddles, Kondapur, one of the strong members in our team. She has developed her expertise in working in level 4 NICUs, and she handles extreme preterm babies starting from 24 weeks and is trained in high frequency ventilation, inhaled nitric oxide therapy, therapeutic hypothermia, and the armamentarium of NICU services. She is very passionate with point of care ultrasound focus in units. Dr. Srujana will be the fourth panelist for our day, a young neonatologist. She works as clinical associate in our team. She did her fellowship training from our own center, and today she has blossomed into a neonatologist managing complex extreme preterm cases, post-cardiac, post-surgical cases, term newborns with hypoxemic respiratory failure. Thank you all, 4 of you, for joining us today. I hope you have mics, wireless mics. Can the team please provide them 2 wireless mics? So the reason we are having this panel today is because we know that India, with a burden of close to 13 to 15% prematurity, is the home to the largest number of preterm deliveries across the world. Amongst this burden, 4% births happen to be extremely preterm, less than 28 weeks, where all the difference between the sky and the earth can be achieved by the quality of care in the golden minute and in the golden hour. Now, when we talk about neonatal mortality today, as we speak, it stands at 20 per 1,000 live births. Prematurity and preterm related complications and morbidities account for the highest proportion of neonatal births, and neonatal births, deaths, in turn account for the largest proportion of infant mortality. So further reduction in our IMR and further reduction in our under 5 mortality rate is going to be impossible without achieving reduction in neonatal mortality, and in turn it cannot be achieved without improving survival among extreme preterm infants. Now when we talk about perinatal interventions, we are talking about a continuum of interventions starting from pregnancy or antenatal phase. Particularly, this deals with the management of chorioamnitis or PROM, appropriate administration of a complete course of antenatal steroids, and about antenatal magnesium sulfate, about which we will be discussing a little bit in detail. Then it continues with optimal delivery room management in the form of thermal bundle to maintain a good admission temperature, cord care, with the advent of delayed cord clamping and other strategies to include placentofetal perfusion, appropriate oxygen saturation targeting, early CPAP, gentle respiratory support, early appropriate use of selective surfactant replacement, and dedicated personalized teamwork with close debriefing. When it comes to the postnatal management capsule, it includes continued management of RDS with gentle ventilation, avoidance of invasive ventilation as much as possible, permissive hypoxemia, which means targeting saturations which are conservative. Usually we talk about SATs target of 91 to 95% when we are talking about preterm population, appropriate management of sepsis, early aggressive enteral and parental nutrition, and prevention of complications like ROP and IVH. So these are some of the proven strategies extending across the spectrum, and I shall be discussing these with our panelists one by one. The first that we are going to discuss is something that we all know. It's one of the silver bullets in perinatal medicine, an intervention that has given the Cochrane collaboration its logo, antenatal corticosteroids. Now we all know, and I'm not going to go into the well-known literature. I'm sure everyone here is aware that antenatal steroids are indicated for pregnant women who are at risk for preterm birth between 24 to 34 weeks of gestational age. This is what the NIH recommends. And what is to be given? It is either betamethasone or dexamethasone. The dose is either 2 doses of beta, 12 milligrams, 24 hours apart, deep intramuscular in the thigh, or 4 doses of 6 milligram each of dexamethasone given 12 hours apart. When 24 hours have been completed from the last dose to the delivery of the baby, there are innumerable benefits which include a significant reduction in almost all neonatal morbidities, starting from perinatal deaths, neonatal death, a 34% reduction in respiratory distress syndrome, 45% reduction in intraventricular hemorrhage, a nearly 50% reduction in necrotizing enterocolitis, need for mechanical ventilation, and the incidence of early onset sepsis. Now, the question here is not on the benefits of antenatal steroids, which are well proven. The question here, Dr. Veena, to you is, despite all this evidence, where is the gap in the translation from evidence to practice, and what are the obstacles, in your opinion, that hinder the translation of this important intervention? And how do you think we can overcome that?
It is a challenge for any obstetrician to complete the dose of steroids and waiting for 24 to 48 hours in these conditions like advanced preterm labor, infections, diabetes, hypertension disorders, coagulation failure, and in severe lung and cardiac diseases, in active bleeding conditions like placenta previa, abruption, trauma, accidents. So also in the fetal conditions where the fetus was already compromised with evidence of Aparna C and severely compromised Doppler umbilical artery compromise. So we do usually face challenges in considering steroids in acute chorioamnionitis. There are different schools of thought. One is depending on the severity of the infection and depending on the condition of the patient. So they do consider giving the steroids in such conditions with a good antibiotic coverage. But there is a flare-up of infections because of the steroids. So hence, steroids are not usually recommended in case of chronic infection. In cases of diabetes, it's a challenge again. Definitely to consider steroids because steroids cause transient hypoglycemia. So a continuous blood glucose monitoring has to be continued when you are considering steroid. There should be a increase in the baseline dose from the baseline dose of 40% on day 2 or day 3. And simultaneously, there is a slow decline in the need of insulin later on because the steroids have as early as 12 hours. The steroid has a physiological effect on glucose as early as 12 hours. So
I think the point that Dr. Veena is trying to tell us is there are very hypoglycemic agents. It can be used in hypertension. And it can be used in mothers with PROM. The only absolute contraindication for antenatal steroids is clinical chorioamnionitis, which is an extremely rare entity. In most of the other situations, it is quite safe to go ahead with steroids. So this possible fear or a little suspicious or doubt about the potential efficacy and safety is probably one of the concerns behind one of the low coverage for antenatal steroids. In Telangana state, particularly in the SNCUs, it is said that less than 10% eligible pregnant mothers get a complete course of antenatal steroid despite having the time. Now, another common question that is asked is, we anticipate only 1 to 2 hours for this preterm mother to deliver. Do we still go ahead and give a shot of steroids? What do you feel, Dr.
So, actually, the physiological effect of steroid, considering the steroid, but because the steroid has a beneficial effect of in reducing the IVH and CB.
So there are non-genomic and genomic effects of antidote. Necessary to hesitate to give steroid even if you believe that there is not enough time to complete the course. Even a single dose of rescue steroid may be better than not giving anything at all. The next doubt here is, which is better, betamethasone or dexamethasone? Now, there are very few head-to-head comparison trials. There are few RCTs that have compared directly betamethasone versus dexamethasone, but we have indirect comparisons, beta versus control, dexa versus placebo, which do indicate that there is perhaps a lower risk of respiratory distress syndrome or HMD when beta is used over dexamethasone, and probably there is a advantage towards better reduction in IVH when dexamethasone is used. But none of these are quite well substantiated, and using either of them is pretty fair. But now the problem in India, which has been sort of realized recently, is that we do not have the traditional combination of betamethasone phosphate and acetate, which is what is recommended in Western literature. All the studies in the Cochrane review have used 12 mg of betamethasone, which includes 6 mg each of beta phosphate and beta acetate. And this is not the preparation that is available in India. And hence, the government of India in 2014 came up with this operational guideline, which recommended that a single course of injection dexamethasone must be used preferably in India for pregnant mothers with imminent preterm delivery between 24 to 34 weeks. So this is something that is coming new, but in centers where you are comfortable using betamethasone, it is as well safe or efficacious to use either of them, provided we are giving as much of antenatal steroid coverage to our babies as possible in view of the innumerable benefits that this has. Now, question to Dr. Aravinda Lochani, neonatologist, is, now what do you think about the use of antenatal steroids outside this traditional recommendation, outside 34 weeks, particularly in babies born late preterm, between 34 plus 0 to 36 plus 6 weeks of gestation? Are you, as a neonatologist, concerned about this?
Between 24 weeks and 34 weeks of gestation, coming to the late preterms who are born between 34 plus 0 to 36 plus 6 weeks of gestation, there is a trial called Antenatal betamethasone in late preterm trial, that is the ALPS trial, which was published in NEJM in 2016. In that, they have studied these late preterm babies who constitute around 8% of the total newborns that are being born. So they are also subjected to a lot of respiratory morbidities, needs for NICU admission, needs for respiratory support. So in the study, it was proven that when steroids, antenatal steroids are given to late preterm infants, it decreases the need for respiratory support, be it either CPAP or heated humidified nasal cannula or oxygen therapy, and also decreases the need for mechanical ventilation in the first 72 hours of life, and also decreases the mortality. So this is 11.8% in the babies who are subjected to the steroids versus the control group, which is around 14%. That's why the ACOG recommends the late preterm steroids between 34 plus 0 to 36 plus 6 weeks of gestation also. In this trial, it was found that the only limitation being the neonatal hypoglycemia, which can be, if we adequately monitor it, it can be easily avoided.
So one concern with the use of antenatal steroids in late preterm infants seems to be neonatal hypo to 36 plus 6 weeks. So either one should ensure appropriate feeding, enteral feeding, or if the baby is not eligible for enteral feeding, then in the form of intravenous alimentation and close glucose monitoring. So Srujana, what is your view about repeat courses of antenatal steroids, and is there any long-term concern with the use of fetal exposure to antenatal steroids?
They are saying we can repeat single repeat course of antenatal steroids if the first dose it is taken for more than 14 days as per ACOG guidelines, and gestational age is less than 34 weeks. As per WHO, if the first dose is given more than 7 days, then we can go for the single repeat course. But multiple, there are few studies like the multiple MAX study, which is multiple antenatal corticosteroids in the fetal babies. So these studies have shown that there is somewhat compromise in the anthropometry at the birth. So they are saying that it's better to go for the single repeat course of antenatal steroids.
So a single repeat course of antenatal steroids may be considered if the mother remains undelivered with steroid, or more than 2 complete courses is going to predispose the fetus to anthropometric concerns as well as long-term neurodevelopmental issues. There is also a concerning trial that has come in from the low middle income countries. This was ACT trial that actually showed a borderline increase in neonatal mortality with the use of antenatal steroids in a community-based setting, where the Symphysio-funded height was used for the calculation of gestational age. So with the inherent limitations of this technique for the assessment of gestational age, including the assessment of some SGA or IUGR fetuses as preterm. The results of this study remain debatable, but this is a word of concern, especially in countries like ours where the risk of maternal infections and sepsis is particularly high. Now, coming to the timing of steroids. Now, in order to do all this, one needs to have accurate gestation weight assessment. So, Dr. Anu, what do you think is the accurate technique for the identification of gestational age to decide whether the mother needs to be given steroid versus not? And can we predict the risk of preterm labor?
Good evening. Happy to calculate ETD, but this may not always be ideal if the patient doesn't exactly remember her LLP or is confused because of early pregnancy spotting, or if she doesn't have regular cycles, 28-day cycles with ovulation on day 14. So we have to resort to scan EDD. So according to ACOG guidelines, the most accurate gestation comes from the first trimester scan when the CRM is less than 84 ml and the scan is done less than 13 plus 6 weeks. And then the question arises as to which EDD do we consider, the LLP EDD or the scan EDD. So when the scan is done between less than 8 plus 6 weeks, we'll only consider the scan EDD only if the discrepancy is more than 5 days, and when the scan is done between 9 to 13 plus 6 weeks, we will only consider the scan EDD if the discrepancy is more than 7 days. Otherwise, we always go for the LLP EDD. Coming to the risk factors of preterm labor, this is a pretty busy slide, but in a nutshell, the most important risk factor for preterm labor is a past history of preterm labor. So there is a 14% risk of preterm labor in the present delivery if the woman has history of one preterm delivery, and it increases to 28% with the history of 2 preterm labors. So the other risk factors being uterine overdistension secondary to multiple gestation, polyamnios, macrosomia, infections, uterine anomalies, cervical incompetence, advanced and teenage pregnancy. So basically both the extremes of maternal age and also maternal comorbidities such as PIH, GDM, APLA. So in these cases, the preterm labor may be spontaneous or it may be iatrogenic induced. There could also be fetal factors such as congenital malformations, FGR, IUDs, and in most of the cases of preterm labor, the cause is idiopathic. Prediction of preterm labor. So how do we predict preterm labor? So firstly, we look for the presence of risk factors. In high-risk cases, we can also look at the cervical length of ultrasound. If it is less than 1.5 centimeters, then there is a 50% chance that she will deliver by 32 weeks and a 90% chance that she will deliver by 34 weeks. Whereas if it is more than 3 centimeters, the risk drops to less than 8%. Then there are also some biomarkers which, when present in the cervicovaginal secretions, are pathognomic of imminent preterm delivery. The most important ones being FFN, fetal fibronectin. So this is basically a glycoprotein that facilitates an attachment of the decidua to the placenta, and it is normally present in the cervicovaginal secretions up to 20 weeks. So when this is being detected after 24 weeks, it does become pathognomic of imminent preterm labor, but this test has a very high negative predictive value and it is poorly specific. The other two markers are placental alpha macroglobulin, and the other thing is phosphorylated insulin-like growth factors.
So among all these markers, Dr. Anu, which is the one which is most practically used? Because there may be a lot of
what is commonly used is actually fetal fibronectin, but what should be ideally used is placental alpha macroglobulin, because it has the ideal ratio of positive and negative predictive value.
So there are multiple tools to predict preterm labor and to probably anticipate a high risk of infection. Is this an important cause of stillbirth in our country, and what can you do as an obstetrician to reduce the incidence of FGR?
But still, FGR stands or second in the etiology of stillbirth rate. So there are few strategies to reduce the FGR and stillbirth rates. Definitely firstly by establishing an accurate EDD. This is to first continue the fetal surveillance and optimize the timing of birthing, and address the modifiable risk factors, which includes reduction in the pre-pregnancy weight and cessation of smoking, alcohol, and to enhance the education about contraception, fertility, family planning, so that to defer the pregnancies in the extremes of age in the very young and elderly age group, and detection of maternal medical conditions and close fetal surveillance to optimize birthing, and availability of basic and comprehensive emergency obstetric care. And there is a good evidence to support the low-dose aspirin in high-risk pregnancies with the risk of preterm birth, which reduce the risk of preeclampsia, preterm births. So, do you know that half of the stillbirths in our country and low-income countries are due to the lack of skilled birth attendants at birthing? So that has to be there, and implementing an audit obviously has a significant improvement in the reduction of preterm births and FGRs and stillbirths.
So since we are running out of time, so I'm going to request all the panelists to restrict your doctors and deciding the termination of pregnancy. If you could quickly summarize 2-3 important carry-home messages for all of us, how do you think doctor is useful in this particular population?
The research is not only used to detect FGR but to identify the etiology, the type, and to stage FGR so as to plan the mode of delivery and the time of delivery, and also to anticipate the neonatal complications. So, and the other most important thing is we not only stick to uterine artery, umbilical artery, and MCA, but currently guidelines recommend the use of CPR ratio, which is more sensitive to mild insufficiency, especially late FGR, when the umbilical artery Doppler may be normal. So we always have to look at CPR, and usually, normally it is more than 1. If it is equal to 1 or less than 1, that is when we know it is alarming and we'll have to intervene.
Yeah, so helping us to decide the timing of labor and for 4 weeks with an abnormal Doppler, as Dr. Anu has elucidated, not to forget the role of venous abnormalities, which are kind of pre-terminal anomalies which have a very high risk of impending or imminent fetal demise. Now, Dr. Srujana, it is often believed that SGA babies are stressed babies and probably are at less risk of some complications. Do you agree with this, or do you in fact contradict this?
No, I absolutely agree with independent growth restriction features. So these babies, they need some intensive care as well as the prolonged hospital stay due to some risk factors like prolonged risk factors like hypothermia, hypoglycemia, and severe respiratory issues like BPD, feed intolerance like NEC, and ROP. So all these risk factors they are more commonly seen in especially in the IUCR and the extreme preterm babies. So
she's actually telling that she doesn't agree with the dictum that SGA babies are not at risk of complications. They are as much or perhaps at a higher risk of some complications, particularly asphyxia, hypothermia, necrotizing enterocolitis, polycythemia, and hence they need more vigilant. Tell us something about antenatal myself. Please keep it very brief. What are the adverse effects in mothers and neonates, and what are the benefits?
So, having preterm births has to be initiated with the magnesium sulfate within 24 hours of delivery, and the contraindication obviously is the myasthenia gravis, and also cautiously used in cardiac and kidney function when impaired. And the upper and lower limits would be 24 to 32 weeks of gestation, with a regular dosage of 4 grams should be given as a loading dose, followed by maintenance of 1 gram. And it should be initiated within 24 hours and continued up to 12 to 24 hours. So, we all know the mechanism of action and advantages according to the 2024 corporate. They emphasize on giving magnesium sulfate to reduce the risk of the preterm births. So there is no need to do not re-administer the dose of Maxif again if the delivery is delayed after giving the first dose. So the side effects are the same to the maxills when given to the preeclampsia. So we have to keep the monitoring of all the signs of magnesium toxicity. And for the fetal heart rate, there definitely is changes in the fetal heart rate variability, and the baseline is changed. Obviously, additional benefit of antenatal steroids can be given along with.
So 4 gram loading followed by 1 gram per hour for 24 hours or until preterm delivery, which was earlier. And this is obviously different from the dose that is used for pre-eclampsia. So Dr. Aravinda, do you anticipate a higher risk of depression when Maxil has been used in mothers? How do we counteract this kind of depression?
Yes, ma'am. Babies we should be ready with the resuscitation equipment, everything to counter the depression.
And calcium is used as an antidote when Maxil has been used for mothers. There is a slightly higher risk of neonatal depression, but numerous other benefits like lesser risk of cerebral palsy. Now, would you prefer in-utero transfer when you are anticipating extreme preterm delivery? And can you tell us briefly what is the advantage of delivering such a baby in utero?
Yes, in-utero transfer is different. Some of the things need to be kept in mind when we are referring to a mother. So, because like what is the stage of labor she is in? If she comes in impending labor and she is about to deliver, then no, she may not be able to transfer such a mother. And if the CTG is not normal and the baby is having any legal anomalies, then we cannot refer. So next, if the mother is able to be transferred to the higher center, then we should counsel the family, give emotional and support the financial constraints that they might have. And we should also have a good transport team where during the transport some anticipated complications like respiratory support, surfactant deficiency and all need to be taken care of. Ventilator should be available in the transport ambulance. So after seeing all these logistic difficulties, we can categorize the babies, like babies who are less than 30 weeks, 28 to 30 weeks, definitely if they are transferred to a tertiary care NICU, they fare far more better, because in studies it has been shown that babies who are born outside and then transported have a higher 19% higher risk of mortality than babies who are born after the mother has been transferred and delivered at a tertiary care center. Then between the 30 to 34 weeks, if a neonatologist is available at the referral center, then based on their confidence level, the babies can be treated there. And coming to the conditions where the transfer needs to be done, it can be based on maternal indications where the mother also needs multidisciplinary support, and the baby's condition like needing any cardiac interventions or any other surgical interventions, and obviously preterm babies, they fare better because there will not be any maternal neonatal separation. Like we will be discussing further about early expression of
less than 20 weeks and neonates with cardiac and other complex surgical conditions would benefit from an in-utero transfer. Lesser incidence of mortality, intraventricular bleeds, etc. So, Dr. Srujana, can you tell us when you are preparing to receive such a baby in your life?
First, to maintain the temperature, especially in the preterm babies, we need along with the normal things, polyethylene wrap in the thermal contents, especially if they are less than 32 weeks. And heated humidified gases we have used. Oxygen blender, it has to be used to provide the oxygen. And transport incubator, it has to be there. And TP's resuscitator, it has to be used to deliver the AP delivery with CPAP, which has been advantage.
Yeah, so TP's resuscitator, a polythene wrap, early CPAP equipment, blender, pulse oximeter, these all are going to go a long way in helping us save these babies with intact outcomes. So, Dr. Aravinda, 30 seconds delay the cord clamping. According to WHO, 60 seconds they should delay the cord clamping. Yes, it is beneficial very much in both the preterm and term babies. For preterm babies, it leads to increased circulatory blood volume, increased cardiac output, decreased need for transfusions, decreased mortality, decreased IDH. And in term babies, increased oxygen, increased iron stores and myelin content and cognitive skills and motor skills in the infancy. So these are the benefits of delayed cord clamping, and everyone should aggressively practice the delayed cord clamping, which leads to transfer of 25 to 30% of the residual intraplacental circulating blood volume to the baby. Dr. Veena, are you concerned about delayed cord clamping from the
Yes, there are some placental circulation is happening, like in abruption cord avulsion, and we cannot follow this in when the baby is born late and in conditions like HIV, HPCG infections, and in monochorionic twins, which is contraindicated for delayed cord clamping.
So few contraindications, but in most vigorous term and preterm newborns, delayed cord clamping is safe and doesn't increase the risk of host. And we are evolving the concept of doing delayed cord clamping even in babies who are having depression with these kind of warmers, mobile resuscitation trays, wherein resuscitation with an intact cord can be initiated, and probably this is going to be one of the most important changes that may come in the upcoming editions of the neonatal resuscitation. We also have the option of cord milking in babies who are more than 29 weeks, where the baby may be depressed and you may want to initially start the baby on resuscitation. So, Dr. Srujana, what are the components of thermal bundle and why is admission temperature an important outcome for us?
That thermoregulation bundle usually contains like a pre-cap should be there. There should be polyethylene wrap for preterm babies, and there should be thermal mattress with heated and there should be heated humidified gases and transport incubator. And delivery room temperature should be maintained between 23 to 25 as per NRP guidelines. These hypothermia in the newborns, it is very important because hypothermia at the time of admission, there is studies have shown that for every 1 degree fall in the admission temperature, there is 28% increase in the risk of mortality and 11% increased risk of late onset sepsis. Along with this, there are also increased risk of complications like hypoglycemia, metabolic acidosis, BPD, feed intolerance, mortality.
Thank you, Srujana. So, I request all the obstetricians who are running their own maternity homes and setups here, kindly do think of investing in a blender, a pre-warm, a warmer, and heated humidifier the risk of mortality and morbidities, and also a TP's resuscitator which can help us to provide early CPAP, which is also something that is used for providing gentle early respiratory support, better management of RDS, and reduction in the need for surfactant. So for want of time, I'll probably leave some of the other questions which are core neonatal oriented, which may not be of much interest for the obstetrician predominant delegates group that we have today. These are all the summary points, and together as a team, there is a lot of difference that we all can make for improving the survival of, particularly of babies born between 24 to 26 weeks, in-utero transfer, antenatal steroids, complete course, antenatal magnesium sulfate, appropriate delivery room care, and providing non-invasive support in the NICU as much as possible, having bundles and checklists to prevent infections, to prevent sepsis, IVH, retinopathy of prematurity, having human milk bank, and trying to decrease the incidence of necrotizing enterocolitis. I thank my esteemed panelists for a very kind of illuminating discussion, and hand over back to the chairperson.
Together, a common consensus has to be brought, and the concept of the word delayed cord clamping might convey a different message. I think we should have an appropriate cord clamping. So the term delay can be negatively thought of, and excellently talked. And regarding the steroid, I think we should come to a consensus. I wanted to know about where is Dexama, we started this campaign Dexama in Telangana. I don't know. So I was secretary. So I don't know whether all of them know about that initiation. I don't know.
So this is one of the initiatives.
You factors that checked that and said that she's going to go in for preterm labor and asked her to get admitted. She wasn't convinced, so she delivered normally at full term. So my question is, what is the specificity and what are the indications? When do you actually check for that factor? Do you check for all pregnant women?
Symptoms of pain abdomen with no vaginal changes. In that case, it is appropriate to go for that test, because in that case we can surely tell that they may not going to live if that test is negative, but it is very poorly specific and very poor positive predictive value.
It was a wonderful dexamethasone versus betamethasone just continues, but which one is available? Our obstetricians use that one, so at least some of it should be available. And repeated courses, I give people, there are repeated courses of steroid, and as neonatologists we often see that 5 courses of beta or dexa have been given since 24 weeks of gestation, and so that has to be discouraged for me. And late in pregnancy, between 34 to 38 weeks of gestation. Use of DEXA is also very rampant. There are people who love DEXA and they just don't want to not give it even at 35, 36 weeks. So they also have to be cautioned at times that hypoglycemia is something, it's a silent killer. And increasing risk of hypoglycemia in settings where we can't ensure monitoring blood sugar very efficiently. So that can be very counterproductive. Recently a paper was published in which at 5-year-old developmental delays were examined and MRI was done, and hypoglycemia came out to be one of the most important causes of developmental delay. So all these things could be contributing a little.
So this topic is almost included in all the perinatal or neonatal the same antenatal steroids, delayed cord clamping. We all know the benefits of various interventions, but still we see that all these are not being practiced in many centers. So we should see that we have a very good survival rate of the babies and long-term neurodevelopmental outcome also. So better we all should implement all these in all the centers, maybe it's a tertiary care or small centers. We should see that all these things are getting implemented. Thank you.
Many times we get a call that 29 weeks or 30 weeks and there is leakage of membranes and we are taking a resuscitation. So how appropriate is that once leakage is there at 30 weeks and rupture of membranes is there and taking a resuscitation immediately. So
I think the absolute indications for termination obstetricians would answer this better, of course, but these would include presence of fetal compromise, non-reassuring fetal heart rate, presence of active signs of infection in the mother in the form of fever, leukocytosis, maternal or fetal tachycardia, or if there is absolutely nil liquor potentially compromising the baby's well-being. Or in some cases, the mother might proceed into active preterm labor as well. When she is in active labor, it becomes difficult to prolong the pregnancy, especially when there is oligohydramnios. We may feel that it is better to take her up for a cesarean section. Barring these indications, I think most obstetricians would wait and give some time for antibiotics and antenatal steroids and Maxel to work. But then again, it really depends upon the gestation age. If the same situation arises beyond 34 weeks, I think most of the time obstetricians will be comfortable to deliver the baby. You can correct me.
So, according to mother and baby are stable, we can do the weekly after admission of observation for 72 hours. She can be discharged with educating what are the signs of infection and when she has to report to the hospital. With all these things, she can be monitored on weekly basis or bi-weekly basis depending on the maternal and fetal condition, with regular leukocyte count and with a scanning to look for the AFI and continue the pregnancy till 34 weeks, and then we can consider delivery after steroid covering.
So was medical legal
Has to be considered after explaining to the couple and family. Only with their continuous compliance we can continue this.
Thank you again on behalf of the Cuddles team, all the panelists and the chairpersons. The momentors will be given away in the area beside the lift. Thank you everyone.